Okay, so thank you everyone for coming along to this really important session today. So Angela's given you the background and the inspiration behind the session. So to get us underway, we're going to have a discussion panel soon, which will involve, as Angela said, CAB members, a selection of CAB members. But I just want to say we also have CAB members in the audience who won't be up on the stage, and I am going to also give some of those CAB members an opportunity to make some interventions as well. But please have your questions ready. You can send them through, or just go straight to the mic, which is always good. So what I want to do next, though, is introduce Robin Montgomery. Robin works for INPUD, the International Network of People Who Use Drugs. She is our incredible, amazing, always fabulous CAB coordinator. She's an incredible global activist and specialist in advocacy and strategic advocacy in particular. She's truly amazing, and she is our CAB coordinator, and she's going to do just a brief overview for you. For those of you who don't know much about the CAB, just give you a bit of background on it, but also talk about how the CAB has been really instrumental and important in these recent times of difficulties. Thanks.
Thanks so much, Annie. Hi, everyone. Welcome. My name is Robin Montgomery. I am from the traditional unceded territories of the Algonquin Anishinaabe Nations on Turtle Island, what we now know as Canada, and Ottawa, Canada in particular. It's a real pleasure and honor to be here. And thank you so much, Annie, for that really fantastic, very generous introduction. All right, so today really wanted to talk a little bit about and set the context about who we are as a community advisory board for this very large 10-country research project. So as we know, hepatitis C continues to disproportionately affect people who use and inject drugs in low and middle income countries. This is in countries where stigma is pervasive. There are weak health systems and often very limited access to harm reduction services. Additionally, communities have historically been excluded from decision-making tables, from decision-making processes, often leaving interventions and research, which we help to implement, poorly executed and really just completely separate from the lived realities of people who use drugs. So from the very beginning of this project, it was a focus that of the three consortia leads, which are Frontline AIDS, Médecins du Monde, and PATH, it was their commitment to embed communities and prioritize meaningful engagement from the very get-go. This led to the creation of a cross-cutting global community advisory board that's chaired by the International Network of People Who Use Drugs, by INPUD, alongside with our close partner, community-led technical partners such as COACT, and our recently elected vice chair, Kwame Juma of TANPUD in Tanzania. So this is a little bit about where we are and who we are. So how did our CAB members get selected? Well, they were nominated by country-level community-led networks of people who use drugs, together with our consortia leads and community partners. So the CAB includes up to 2 members from each of the 10 countries, as well as 1 representative from 2 regional networks. So as a critical governance mechanism, the CAB has played really a central role in shaping protocols for both low dead space syringe and needles, as well as long-acting buprenorphine research and implementation studies. So we have 20 CAB members. Over the course of the last 2 years, CAB members have reviewed study designs. They've ensured that all of our information materials, our focus group guides, are all in plain language, that they're culturally competent, responsive. They've developed peer-led information resources, and of course, they've championed the importance of client choice in opioid agonist treatment. We have been trained and empowered to lead focus groups and key informant interviews that have really made the data collection itself community-led and community-owned. And this approach really has shifted accountability at its core, because it has embedded from the very center the principle of nothing about us without us. And it's now embedded into the heart of the HCV portfolio projects. So the impact has been really tangible, right? The protocols were revised to reflect the lived and living realities of people who use drugs. Recruitment tools have become more accessible. Community education is improving demand for new interventions. And at a structural level, the CAB's influence has really been recognized internationally, as well as in national research protocols and in ethics reviews. So we meet at minimum quarterly, usually online. We also try to meet at least once a year in person. So we've just had our third in-person CAB meeting here just on the margins of INSU, and it was a wonderful day full of learnings. But really beyond the research and intervention work that we do, we have been able to really activate our advocacy voice at a much higher level. And a lot of this, as we're going to hear today, has become a response to, an emergency response to, our changing political and funding environment that is happening around us. So here are a couple of examples of how we have activated our voice. So following the funding cuts that came at the end of January with the withdrawal of US foreign assistance, we held an emergency CAB meeting to assess what the early impact was going to be, or what we were seeing on the ground with our communities, with our partner service providers, and how our governments were reacting and responding. This led to Input's global report that you can see here. It's available on Input's website, called The Human Cost of Policy Shifts. It also spurred us to reach out to the executive management of Unitaid itself and to raise awareness about what was happening on the ground, not necessarily to raise flags about how this could directly impact on the project itself, but more so around what this means for the harm reduction movement writ large. And so this letter to the Unitaid executive management resulted in us having a meeting with the executive director of Unitaid and led to the budgeting process, so that we were able, together with our consortia leads, to reallocate resources so that additional funding was available for the work of our community partners and advocates on the ground. So just absolutely amazing. We're also seeing really significant and very scary shifting drug policy landscapes around the world, and some within our 10 countries. And so here again, we are raising our advocacy voice and trying to identify platforms, rooms, and spaces where we can raise these alarm bells. One of these is with the Strategic Coordination Group, which is an interagency group of the UN. There are donor organizations and, of course, community networks of people who use drugs. And here at the end of the month, we will be having a meeting to strategize on 2 specific countries in particular on how to move forward and really ensure that people who use drugs in those countries are protected and their human rights are preserved and advanced. So just quickly to wrap up, because you don't really want to hear from me, you want to hear from our CAB members. This is what happens when you invest in CABs of and for people who use drugs. This unique approach is already inspiring many similar approaches in other areas of harm reduction research globally, and hopefully is going to be setting a precedent for future research consortia in global health, demonstrating that when you have inclusive governance structures, inclusive decision-making, that can meaningfully guide evidence generation, then really what we are doing is accelerating access to health innovations for people who use drugs. And this is us. Thank you very much.